Okay, so um, this time I'm gonna kind of talk about how to kind of create a 101 ultrasound 101 workshop with kind of like your own, like what you have available to you. I think we've done a lot of what to do if you have from all these different institutions that have lots of resources, et cetera, et cetera. And so I thought it would be helpful to kind of talk about how myself and some other people have kind of created an ultrasound workshop with just what we have at our institution. So this is also kind of an open ended forum. So if there's any point where you're like, wait, what do you mean by that? Or what have you, just go ahead and stop me. There are enough of us that, it can kind of make it a more of a small group discussion and can talk about like your individual institution. I do have some time at the end to do like specific discussion, but we can stop it at any point. This is for you all's benefit. And we have the whole hour, but I don't know. It'll just depend. I don't think it'll take the whole hour. So, want to give you guys your time back if needed. So, we're gonna get started. Let's see if I can move this forward. Okay. So first off, why is this helpful? You guys kind of already know this, but as we already know, POCUS adoption is uneven across specifically hospitalist medicine. And a lot of workshops that people bring up or talk about are oftentimes too ED centric, or they're to the NICU or the PICU, or they're based off of your, they're based off of, you know, their specific applications, and there's not really much that's helpful to the hospitalist. So, and we've also found that, we're all busy, right? So we want to create a workshop for our peers and for our hospitalist fellows to, we want it to be practical. We want it to be relevant to the bedside, and we want to make it easy, for new learners to feel like they can utilize it. So you want a low barrier entry point. So before you begin, there are questions that you really need to ask. So, um, is this really a one-on-one workshop that you want to do? And so if it is, then these are kind of the goals that you want them to have to understand what POCUS is and is not. So a lot of times what I have seen my attendings, misconception, our colleagues, is that POCUS is equivalent to diagnostic. POCUS can answer nebulous questions. It doesn't really, it's a binary yes or no modality to answer discrete questions, and it does not replace diagnostic imaging. So we want them to leave with that in mind, because we don't want them to be like, well, I have these two sets of skills and I am going to, you know, do an echo now. Like, we want them to understand what the scope of POCUS is. We want them to be able to, help them to generate those binary clinical questions. And we want them to understand, how do you hold a probe? How do you turn on the machine? If I had a clinical question, would I feel comfortable enough to at least turn the machine on and maybe try? And we don't want them to leave overwhelmed either. So this isn't necessarily unless you want it to, in which case you would probably need to add a couple of more modalities, or pre-test, post-test, a little extra time to understand, to add it to any sort of certification. This should not teach them how to replace any diagnostic imaging. And then this isn't really like a mastery workshop. Like, this isn't what we want, that we don't want that to be the takeaway. So you always want to figure out who your target audience is, because that's going to change what you're going to teach and how you're going to teach it. So is it going to be your fellow hospitalist attendings? Is it hospitalist fellows? Are they APPs or residents, med students? Are they nurses? What is their baseline exposure? And then what are the biggest clinical like pain points? Like, what is it that they talk about all the time? Is it vascular access? Is it bladder scanning? Is it, man, if the ED sends one more kid up here with a chest X-ray and puts them on antibiotics, I'm going to scream. Where are the biggest pain points? And so kind of cater to that for that audience. So these are kind of the high yield, kind of easier applications that are pretty great entry points that I've used for nursing, I've used for residents, I've used for my colleagues. So bladder volume, urinary retention, like confirmation of Foley placement, lung. So understanding what normal lung anatomy is, lung effusion versus consolidation. Also, what are B lines? What does that mean? Doing soft tissue, so cellulitis versus abscess. Vascular access seems to be, of course, the residents, the medical students, and the nurses, of course, seem to be more they got more out of the ultrasound guided PIV portion than I feel like my attending colleagues did. But that may be institution dependent. And then you could do IVC volume status that doing that in general is kind of a hot topic. But if you are, doing that in the context of maybe a fast exam, which a fast exam in itself, we don't typically do on the floor, but if you're going to do something like that or within a rush exam and you have some learners that have a little bit more exposure, doing it within one of those protocols could be helpful. So you want it to be where if people can imagine doing it on their next shift, it belongs in ultrasound 101. So like you're not doing cardiac, you're not like doing intussusception, you're not doing an appendix ultrasound. Like you want something that is easy to replicate, has this low barrier to the like being able to physically manipulate the probe, as well as like understanding the basics of ultrasound in itself. So um, you want to, in some things to keep in mind for the different learner levels that I've personally seen, and some of my ultrasound friends have also seen, is that, a lot of medical students and residents and fellows at this time have some prior exposure to ultrasound. So if you're doing like a resident or a learner-based medical student, resident fellow-based workshop, it might be worth screening what their knowledge base is prior and stratify your small groups based off of what their exposure is. And then nurses and APPs, like you screen them for what their exposure is to ultrasound. Of course, for nursing, it may not be much, especially if you're not doing ultrasound guided IVs for all nurses, which is what our institution currently does. We just have a vascular access team. Though they don't have direct exposure, they have very similar skill sets because they're often using like vein finders and bladder scanners and that kind of hands-on skill set of holding a probe and manipulating it in orientation in space can actually translate. And so you sometimes can move a little faster with those learners as opposed to more seasoned attendings who really have not used any of that hands-on. So the psychomotor component is not necessarily there, as well as the like interpretation component. So thinking of it in this way, like true beginners, you maybe want to do like bladder, basic lung, soft tissue, identifying objects suspended in gel just to get the ultrasound basics of like, this is how you fan, this is how you slide, just to understand that orientation. And then translating it to one or two basic applications is probably going to be, you're going to get the most bang for your buck and people are going to be the most excited because they're getting those basics pretty quickly. And then with some exposure, they have, like I talked about, using different lung patterns. So doing normal lung plus abnormal lung, or setting up your workshop within the scaffold of a fast or a rush exam, or vascular access. In addition to what you can do for the true beginners. And then with a mixed group, a combo of the above, but also thinking how you maybe want to set up your groups. So You can kind of do it a couple of different ways, and there are pros to each. So thinking about like what the makeup of your groups might be or what your learners might be. So you could have like your higher learners mixed with your true beginners. So that way there can be some peer-to-peer direction or teaching. This can especially be helpful if you are kind of limited on the number of preceptors that you have, or if you have an instructor that's stretched across stations, having that peer-to-peer insight and help can sometimes be really good. Or, you can have versus if you just keep them all in the same exposure level, which is also fairly helpful. I think you just want to not have like a super um, like a someone who knows a whole bunch about how to do ultrasound and someone who just doesn't know anything. Kind of want to still have um, close-ish um, exposure levels. And then you could also do where to stretch your higher learners, if you are doing this mixed model, is to have some stretch goals for those more experienced folks. So like, okay, you got this. You got this lung sliding in the longitudinal. Now show me the transverse and describe it. Or, show me, the at the PLAPS point where you like where is the PLAPS point and how are you going to optimize that, or where might you see an effusion or differentiating a loculated effusion and having them identify some abnormal imaging for your kind of high, your more experienced folks at those stations to keep them engaged as well. So um, in terms of like stratifying like the length of the workshop and how long and who you want, like how long you want this workshop to go, one is like how much time do you have? Like, is this something that is a dedicated time in the afternoon where you have like 90 minutes to 2 hours? Is this, well, I really only have like a division meeting, or I have like a short didactic time that's only an hour? So it also depends also where you want this workshop to live. Like, is this just like when I did it, I really just wanted to expose my hospitalist colleagues to like what ultrasound is. And I was going to kick off the curriculum later in the year, but I really just wanted to get buy-in from them to get machines and to allow time to teach during division meetings. So it was a little more, the first year was a little bit more of like marketing of like, this is all that can be done. Here's some cool stuff. And then the next year after that was um, a little bit more dedicated to one or two applications because I knew I had the buy-in from those participants. So you can also you want to have you and you can also see like, are you going to pre-test before to figure out like what all you're going to teach? Are you going to allow your groups to kind of self-select or just like not group at all? It just depends. And then when thinking about like, oh well, I have like this entire afternoon, just think like for a basic 101 workshop, unless you are trying to go into something more intensive, anything that's more than 3 hours can be really overwhelming, especially for true beginners. Our first year, we had a 4 hour block and we had four different applications, and we were still like done by hour three because it was just there was only so much that they could absorb. And by that third hour, it was just like, and I'm done. It's time to go. So, if you feel like your folks can do more, then go for it. But just be prepared that you may notice some burnout. They may be kind of tired by that second or third hour. So, and it's better to have them leaving excited and not overwhelmed and drained. So here are a couple of different outline examples. I've done both. I've done some other ones. These are kind of some where you can think about it, but the goal here looking at this is that you don't want your didactic to really go over 45 minutes. Like if you think these people are super excited and they really want to know about ultrasound basics and you really want to get a bunch of the application kind of didactic knowledge out right out front, then maybe an hour, but 45 minutes is really kind of pushing it. And so whether you're doing like a more full didactic or a mini didactic, you always want to have like some of the basic things of like what is POCUS, what is not, some basic knobology. You can do that in the beginning. I've done it both ways with some of my more experienced learners. They like having that. With some of my less, they're like, I have no idea what you're talking about. And you throw physics out there and then you just completely lose them. So, if you're not sure, less is more, and you can talk about knobology within those small stations, and then you can more, tailor that learning to the learner. And so then, with the first one on the left, having small group stations, you want 2 to 4 applications. And then you want them to be about 30 to 45 minutes each. You can have them be 15 to 20 minutes. Like it just depends on what all you were trying to teach them. So you can have a short introduction with your preceptor. They can give like a short additional didactic if you want to have it be 30 to 45 minutes. Same with if you're doing the mini didactic. Like if you're putting less up front, expect that you maybe want to have more didactic at each station to kind of give an introduction and get everyone on the same page, as opposed to just be like, go scan, good luck. Um, so it just depends, one, looking at the bottom, seeing like how many preceptors you have. Like if you have enough faculty to kind of do the mini didactic than small group stations, I have found that that sometimes works better for like your beginners. But if you're trying to work with what you have, the left also works as well. You're still gonna meet those goals of like having them feel like they're ready to try and scan after this workshop. So, like I've said already, keep it short, keep it simple. This isn't grand rounds. What is it? What is it not? Talk about your scope. You really want to emphasize that. And then a clinical scaffold, which I'll show in a couple of slides. And then you don't really want to go over 3, maybe 4 applications. And then you could do a reverse classroom model if you're trying to cover more ground. But also keep in mind what the bandwidth of your audience is, because you may expect them to come in and actually do all the pre-course work, and they haven't. And so then you're kind of stuck. So have a plan B in case, if you plan on doing this reverse classroom model. It can definitely work, but like I said, you gotta have a plan B just in case there's not the bandwidth to do that. Um, so an example kind of like outline of like what you would want your sections of your didactic to be is like, I'm just going to drive the point home of like what is POCUS, what is not, like be a very, very simple definitions. And then like how you frame your clinical question, and then using a POCUS exam framework for them every single time. Sometimes that helps, especially with people who have never used it before. So like, what do I think about every single time I'm about to scan someone? So like what probe, so you can use the mnemonic PADGO. There are a couple of others. This is just the one that I started with and I just haven't really varied from. If there's a better one, please tell me. But starting with what is your probe? What probe are you picking? What application? To what depth are you generally going to be? Like even in that application, is it still too deep? Is it still too shallow? Getting your brightness of the image, like what is your like gain that you're trying to get? What is considered your complete anechoic spot to orient everything around? And then with orientation, like what cuts do you want to see? And then you can kind of use within each application, whether you're doing that didactics or at the station, you can use this as kind of that scaffold of like, okay, so like for the probe for lung, I'm either going to use, a phased array or a linear probe, depending on who they are. And then I'm going to use the lung preset, but say there's not one, could you do nerve? And then for depth, you want it to be fairly shallow. And then for gain, like you don't want to overgain, you want to have it a little less gained, and in order to like see those beelines and see those ants marching on a log. And then for orientation, like am I in the longitudinal or the transverse? And so you know putting it within that scaffold can be helpful as well. And so stations are the way to go for these workshops, as you guys probably already know. It's easier to scale, you have less performance anxiety. And so we found that like 3 to 4 learners to one machine to one instructor is really good. You can go up to 5, but kind of that 3 to 4 is kind of that golden ratio. And so these are some examples of different station layouts that you can utilize. These I've used a variation of all of these. I do include like ultrasound assisted LP as a possibility if you have, so like when the year that I tried to do PIV with my colleagues, they were like, well, actually, that's cool, but what about LP? And so we ended up doing more of that, which is a little bit of a slightly more difficult procedure or a difficult application, but a lot of the concepts are kind of similar. So we did that. So it's a possibility to do all of those. And so you notice that in a lot of these, I put ultrasound basics as a station. And so the biggest issue that I see for learners that you guys also probably see is that um, their understanding of the orientation of the image in space to where their probe is very difficult. And so that's a difficult concept for them to grasp and grasp quickly in just the setting of like an image because they're trying to like remember the anatomy, think of the anatomic plane, and then put that anatomic plane within what they're seeing on the ultrasound and the orientation of it, right? But if you use kind of simpler objects, so what we typically do is we have a couple of like pans, which I'll show you guys later, of like gel or of an ultrasound like DIY Phantom that just has like basic shaped objects in it. Like I've done like blueberries, I've done blocks, I've done stars, I've done just like basic shapes. And then I put a thicker layer of gelatin over top. So they can't really see what that is, but they have to try and like figure out and guess based off of their orientation with their probe what that shape is. And then I have like a picture like as like an answer key to kind of show like what it's supposed to look like. And so it's a more basic way to kind of drive home those points of like, well, if you fan this way or you rotate the probe 90 degrees, you're better able to see XYZ. And so that kind of helps them with that concept a little bit better, especially if you don't have any of those like fancy like sim machines that are like, well, when you do it this way and we can show you the exact visualization of how the probe works. Like not all of us have that. So this is kind of a nice way for people to understand that concept of like how an ultrasound probe views an image or like how it's cut to be able and have them try to mimic or how like repeat an image that we have already created. So that has gone over fairly well in all of the workshops that I've done so far. And then scaling up or down in terms of like how much abnormal you want to include versus just normal. And this is not like exhaustive, by the way. Like there are so many other ways that you can do this. In terms of like faculty scripts, you want to remind your faculty that they should be focusing on like them holding the probe, that scaffold if you're going to use it, and like how to orient themselves with whatever they're imaging, how to optimize the image, and then like how do you get like a normal image before necessarily looking at abnormal. And then want to avoid like, especially with your true beginners, over teaching your pathology and like throwing a bunch of stuff and being like, let me just show you everything. Of course, keep that in mind and can stratify and differentiate with each of the learners in the groups, but less in some ways is more, keeping it simple. So what about equipment and like people in general, how to get them and how have I and some of my colleagues kind of tried to get some of this stuff when we don't have like a program in place. So the biggest thing is the machine bottleneck. That's really the limiting factor for the number of stations you kind of can have and like how many faculty you may need. It's very, very common. Like it happens all the time. We're always like, how many machines do we actually have this time? Like, where can we grab them? And so you kind of have to get creative. So these are some ways. So of course, if you are in a hospital system that where other departments already have machines, like just ask. It does help to like schedule your workshops like way in advance and then like so that way they can plan that the machine might not be there and then potentially on low volume days. I tend to schedule our workshops kind of in the spring. And then like, are there old machines in storage? Asking your radiology department. All of these subspecialists can have machines. And then don't overlook like your handheld machines, as well as like your medical schools. Sometimes medical schools are trying to teach ultrasound and they also have old machines. We had a bunch of our medical school switch to Butterfly, and so we were able to utilize some old oh God, I can't remember what they are anymore. But we were able to utilize some of their older machines, which was some of the old Philips machines we were able to utilize. Also, like contacting your local vendors, that actually works really well. You can start with who your hospital is already affiliated with. They may have already sold you machines, but they are always trying to find ways to sell more. So by bringing machines and doing education days, your radiology department or any other department that maybe already has some point of care machines may have like with their contract that, you know, there are education days that can be added at no extra cost or that comes along with it. So it never hurts to ask them and contact your regional vendor and then asking other regional vendors in the area as well. So of those kind of big names, like I'm not affiliated with any of these guys, but you know, like Sonosite or GE, there's a big market competition in my area. So I was able to ask one or both of them, and they both were able to provide me 4 machines. So, and then I had my own personal, and then we had our department Butterfly, and then I was able to get one from our ER. So, you know, that's 6 machines, 6 stations. That's great. Um, but they can almost get as many as you need, and don't overlook those handhelds, like I said. And then, you know, it never hurts to ask. The, you know, worst they can say is no. But I've heard that this works quite well. Um, Again, with faculty and instructor selection, like you don't have to like get a little creative, especially if, you know, there isn't a program already. So if you have ED, PICU, NICU, anesthesia, people from the med school, they may not be affiliated, they may not know peds very well, but you know, you really just need people who can help with probe orientation and some of those basics. The same with like your vascular access nursing staff. Every year our VAT, our vascular access nurses come and help, even if it's not for ultrasound assisted, even if it's not for PIV. They're very helpful in terms of like, well, you should turn your gain down on this or turn it up on that, and are very good with kind of the knobology stuff. Sometimes your vendors have ultrasound techs that are also able to help and man a station. I had that the last 2 times. They were very helpful. Again, with basics and trying to optimize the image. They're not, you know, they won't do any interpretation, but they are very good with optimizing imaging. And so again, I'm going to drive that point home of that ideal ratio, but you can kind of have one preceptor per 2 stations. It is going to be a little bit hectic. And then phantoms. So you don't need to buy a bunch like on the internet and spend $1 million to make them work. So like sometimes just having something is better than like perfect, but it's just not going to happen. So one of the easiest things and low hanging fruit that you can do is, you know, set the expectation, tell your folks that are coming to this workshop that like wear comfortable clothes, wear clothes that you may have to wear sports bras, wear sweats, something that where you might get gel on it. And that are you comfortable ultrasounding each other? And if you're not, and if they aren't, like setting that expectation beforehand of like, so and so does not want to be ultrasounded, but you know, seeing who of the participants are willing to ultrasound each other, because it's so easy to be able to do like skin soft tissue, IVs with veins, lung, and bladder. Bladder can be a little bit questionable, but with how low sometimes you have to go. But again, like setting the expectation and being upfront, and it's like if you are uncomfortable in any way, you don't have to. So setting that as a possible. If you don't, and that's not something you're interested in, you know, there are often residence fellows, like other like medical students, other faculty, are often like for something like this are often very willing, surprisingly, to help as kind of like models. Same with if you have faculty that have kids, like getting them. I've had friends, fellows, children come and bring them to be ultrasounded, and you give them some popsicles and like something shiny and a badge, and they are perfectly happy to let you ultrasound their lungs or often their lungs or their soft tissue is really the easiest. But of course, don't forget to thank whoever your volunteers are. So phantoms that I have found that have worked that are DIY. Um, I really like the DIY ultrasound compendium from out of Australia. They have a lot of different resources. This paper in particular, they actually went through a bunch of different types of like mixing Metamucil and gelatin at different ratios to see what the ideal was. It's a fascinating paper, and I included it in this PowerPoint. But this YouTube video has a similar ratio, which is really helpful. If you don't, another option is ballistics gel. It's a little bit more expensive, sometimes can be hard to obtain, but when in doubt, if like this is your first time and you're like, I just need anything, like you can get so much gelatin and Metamucil at the dollar store, on Amazon. Like it is very, very easy to make. Your kitchen will smell like orange beef, but at the risk of that, it's not. It's actually very helpful. And so all of these other things, like with IV ultrasound models, all of this I got from the DIY Phantom Compendium. Drilling holes into the side of like these Tupperware containers. Sometimes what I'll do is from the hospital, I'll get like the tubing, the flexible tubing, I'll pull that and I'll put that across. I've used dowels and filled like the really narrow balloons across here for IV models and left that in. And then those can sometimes be refilled with ballistics gel or with Metamucil. The ballistics gel will last longer, it's more reusable. But like when in doubt, and this is your first time, then using Metamucil and gelatin never hurt anybody. These are some examples this is from a paper for how to do an ultrasound assisted LP more with the gelatin model with ballistics gel. And then I think this one was also with gelatin and food coloring, I think. And they used that flexible tubing that you can get at you can either get at like Lowe's or Home Depot, or you can get it in the hospital. This is my version that I tried, and I couldn't pull off the sacrum. There's a lumbar spine model that you can get on Amazon that I'll like link if people want to. And I got some hemostats and filled this like flexible tube up with colored gel, and then I put gel on the back and another layer. It worked questionably. I think if I had ballistics gel, I would do something more like this rather than this, the top rather than the bottom. This on the far left is an example of just random objects that I put in, and then I did a layer of gelatin over top, and that was fairly successful. And then on the far right, what I have is a really good lung model actually for lung pathology, not just for normal lung. So the people in this figure, they used uh, either a stick, they used like dowels, but I went out into my local woods and found sticks that were relatively straight and seemed about the diameter of a child's rib, and put that within that gelatin Metamucil mixture. And then this is just one of those like flexible resin molds. Again, I got it on Amazon. I got like a set for like $12, but you can also do like you can get these like just plastic containers at the dollar store. Like you don't have to do that. I was just trying to be bougie. But then you get flat polyurethane dressings. You soak that in water and then you put that over top of your like ribs. And by having the person move the probe across that dressing or that model, that actually can mimic B lines. And it was actually it wasn't super, super accurate, but it was actually very helpful and it helped to drive the point home of what a beeline looked like, as opposed to like hunting along someone normally to be like, okay, oh, and that little spotlight, that's a beeline. So that I found was very helpful. So, you want to try, if you think you're going to be doing this again and again and again, eventually you want to try and make something that's reusable. But, find something that doesn't mold. Again, after a while, the Metamucil and the gelatin will mold, just letting you know it doesn't last forever. Um, do keep it simple when you're creating models, and you don't just have to use that one website. YouTube is full of different DIY phantoms. And then if it doesn't work out, like if you try it and you're like, oh, okay, I think that worked, but I think it worked at home, but in real life it didn't really work, that's okay. People are still getting hands-on. And then networking is your friend. If you do want official phantoms, pool with other departments. We had our ER, we have not done this yet, but our ER actually kind of partnered with our Old Dominion University, their engineering department. And they were actually able to 3D print some like spines and some like abscess molds to create abscesses. So, you utilize those resources as well because they are always looking for projects and things to help out with. So here's some personal lessons learned of like teaching ultrasound basics for more than 10 to 15 minutes, left absolute beginners lost and uninterested. Non-biology at a station or within context of an application was much better received. Nursing learners liked the longer didactics actually than the shorter didactics, which I found interesting. And then people do get really excited to help put these things together. Like you may feel like you're a burden, you're not. Like people are really excited about this. And so take advantage of that. And then also like feedback. Like at the end of like no matter how the workshop went, like sit your people down or find a time like shortly after and get feedback and see like what worked, what didn't, what did they like, what did they not like. Because that's going to help you, really tailor your next workshop. And also you kind of as you build a program as a whole, the more feedback you get, the better. Again, you don't need a full POCUS program. It's okay to start small. The perfect workshop is one that actually happens. And then I've driven these points home into the ground. So, um, we can do some discussion on like what are some of y'all's biggest barriers, any words of wisdom if you have done this a lot and want to pass on. And then I will have some other, I'm working on a Google Drive folder of like specific templates of PowerPoints with the different applications on how to kind of do that within the PadGo mnemonic, and then some other like DIY Phantom resources and some surveys that we've used at our institution that you guys can use. That, if you want to use it, great. If you want to build on it, great. If you don't want to use it or you want to see what not to do, you can also do that. So, what we got? I'll open the chat. Was this helpful? Was this not helpful? Is there something now that I'm getting feedback from you guys? Is there something that you guys would like to see from the SIG around this that is going to be slightly different or more helpful?
I think this was very helpful. Thank you. Uh, I think having that sort of resource compendium of all the websites and how to make your own models and what's been a good resource or good types of materials to use is really helpful from people who've done it themselves before already. So thank you.
Course. If, and I mean, I'll send these resources, but if you guys have specific questions, like don't hesitate to reach out to me or to Scott or to send an email to the PHM POCUS email. We can, troubleshoot whatever it is, whatever particular issue you may be finding.
Hey, I appreciate you taking the time to kind of go over some of these things. I'm a ped hospitalist at Michigan Medicine and trying to build our POCUS program. And I think one of the things I'm struggling with is we've tried to incorporate it into our like Wednesday afternoon didactics. So we've been doing some like just sessions on knobology, lung ultrasound, cardiac, and things like that, and trying to tailor it to the hospitalist. In the next phase, we're going to start adding like the actual like hands-on sessions. Um, the thing I'm struggling with is just like getting more people in person in a world of Zoom because like getting people to to get hands on the probe is going to be so beneficial. Are there other ways that you've figured out from like successes to try to get more faculty to come in person? Because like I've tried CME to get credit for that and trying to do things like having like lunch provided for faculty, but have you found any other things to just get people in person more to do some of the hands-on sessions and get their hands on the probe?
I've worked on it a couple of different ways. One of the ways that and it's a little more time intensive on my part, unfortunately, but is I have weeks where I'm like on backup, and so what I'll do is I will stalk my colleagues, not stalk them, but I will follow them on rounds, and I will say like, "Oh, have you thought about ultrasounding this person?" And then I will be like, oh, you want to come in and ultrasound with me? And then I will show them, and then that gets their hand on the probe and also gets them, even if they aren't doing the ultrasound at that time. I am they are starting to think about what clinical question can be asked, and then you're planting those seeds. There's also I do have a lot of buy-in from my division director who really wants us to really take this and run with it, and so she has mandated that certain sessions are mandatory, so where it becomes a professionalism issue. But I don't know how much, which is not great, but it is another option. And then um, everything else, like you are definitely doing, that has been even in all the in a bunch of the literature that is talking about this from buy-in from any division, in any specialty. The biggest is like getting them in and getting the probe. And I think the best buy-in that people found was if you like gave them actual FTE or money to learn how to do this, which I mean, we don't all have. So in lieu of that, I think if you could, I have done the following them around, and then we have done one or two where I will bring in the machine and I will have them do kind of small groups, like whoever is physically there at these CME meetings. But it sounds like a lot of them are in Zoom, so they're not able to like come in and do that.
Yeah, that is helpful. I don't think that because you talked about trying to, mandate people come and that part has been challenging, but I'm trying to, do some of the same things where, we on service, I will come in and try to because we have two machines in our PHM suite, so I'll try to like follow people around. If they have a LP, I'll offer to come in and do it with them ultrasound guided just to get them excited about it and really like demonstrate the value of this that can help them clinically. Because I think a lot of people are just like, oh yeah, this is really cool and it's techy and it's fun, but I want hospitalists to kind of get a sense of like how can it really improve their practice. And I think the other piece that we have to really tailor is like how do we figure out ways to, increase it, if someone is going to actually go through and become um, able to do these scans clinically and have it be part of their like privileges. How do we get them to have additional, um, you know, um, increase their salary to do that so that they feel like, okay, well, if I'm going to go through all this work of not just learning how to do POCUS, but going through the process of like credentialing, having to be part of my medical decision making, how do we then entice faculty to spend their own time? Because I think that's the hard part is we have learners that it's part of their education. Faculty a lot of times have to just do it out of their own time, and if they're not getting reimbursed for it,
Right.
that's the struggle. So I think we're trying to figure out how to make that work and figuring out reimbursement for our scans and how does that come back to the faculty. So we're still figuring out that piece with the billing, but that is helpful.
Yeah, and I definitely agree. It's really hard to mandate when there's so much that's already required. We have talked about, because we're dealing with the same overall, dealing with the same issue. We have talked about not just in the ER, not just in the hospitalist, but with the ER as well. You know, could there be like a credentialing pathway for interpreting images as opposed to the psychomotor component as well? But the caveat to that is, you kind of have to understand the psychomotor in order to understand if you're getting the right image. But that has been brought up as well as a possibility. So that way, even if they aren't going to know how to do the image themselves, or use it in their own clinical decision making, do they have the ability to, if a resident or a fellow came up to them and said, "Hey, I got this image. I think that this is a part of my clinical decision making. What do you think?" Can they interpret that? And so, again, some people say that that's something that is a possibility. Others don't agree, but I mean, I think that's something else to also bring up as well if that's not, if you're continuing to have that problem. But yeah, it's an ongoing issue. It's like I just want to have everybody be compensated for all this extra work they're going to have to do.
Yeah, agreed. Thank you so much.
Of course. And Natalie, future sessions on how to build credentialing pathways within the hospital system would be extremely beneficial. I will definitely pass that on. We do in the Google Drive, we do have, I think, a number of different credentialing pathway examples. But again, every hospital system is different, right? But there is a folder in there to use as a springboard if you haven't already seen that. But I think talking about that is also going to be helpful.
Thank you.
Hi there, this is Rachel. I'm a nurse practitioner actually in a NICU in Boston that got this link, and I'm actually so grateful. This was so helpful. We are in the very early stages of bringing POCUS to our NICU. And I was wondering if that Google Drive is open to anybody. Obviously, I'm not in hospital medicine, but it sounds like there's some really great resources in there.
Oh, yeah, definitely. Yeah, let
Awesome.
me find it and send it to you guys. And then also, that is another thing that us at our institution we're trying to do is where my our APPs are actually have a good amount of exposure and experience with ultrasound, and they are, the constant, right? They're always on the floors. And so we're trying to get them credentialed so it can be an additional teaching. They can be additional teachers, an additional resource for the residents, for the fellows, for the attendings. And then, there is always someone around, even if the attendings don't quite know how to ultrasound or use that psychomotor component, then our APP can go, "Oh, hey, I can ultrasound that," or "Let me see if they have an effusion. I'll just grab the machine." And so that gives them an additional teaching role and gives them an additional kind of specialization to put them in, a slightly different in a niche that kind of helps us all and also can help drive forward the need for point of care ultrasound kind of on a regular basis. But let me find that link.
Yeah, that's awesome. That is our goal, hopefully. So, but it's definitely not part of any curriculum for advanced practice providers that I know of currently. So it's this is really exciting. Oh,
Yeah,
and
and
yes,
there's
thank you, Julia. I saw that collaborative. We are part of that. That's awesome.
so let me copy this link. Okay. All right. Let me get my life together. Oh yeah, the Neo POCUS Collaborative is awesome. And then there is also the POCUS in pediatrics. They're kind of they're the big group. They are across multiple different, and so they help us with they have webinars and different opportunities and resources for um, really anything across multiple different subspecialties. So let me see if I can grab that as well. Um, for
Oh,
you
great.
guys.
Thank you.
Yeah. Okay. Let's see. Other questions, guys? Or anything else? Or any other comments or anything? All right. Well, I will put this email in. They are also a listserv now on the AAP, POCUS in Pediatrics. So you can email their Gmail to get onto the listserv, or you can just join the listserv itself now. POCUS in Pediatrics at listserv.aap.org. And then this is their Gmail. And then Rachel, if you want to continue to get emails from our PHM POCUS, feel free to drop your or direct. You can message me your email, and I can get you um, on our email chain as well. And
Great. That would
anyone,
be awesome.
awesome. All right. Well, if that is it, then thank you guys, and we will see you guys next month. I'm not sure if we're talking about LPs next month or if we're gonna go forward with credentialing, but you guys will hear soon. All right. Thanks, everyone.